Most people believe that if a surgeon recommends an operation, it must be the right choice. The doctor knows best. The hospital has the equipment. The paperwork is ready. Just sign here. That belief feels safe. It feels logical. But it deserves to be examined, carefully, honestly, and without the kind of polished reassurance that too often replaces real conversation in medical settings. Because here's the truth that gets left out of most pre-surgery consultations. The older your body is, the harder it fights simply to survive an operation, not the disease it carries. The operation itself. There are patients who went in for routine procedures and came out permanently changed, not better, changed. A man who walked in with back pain and left unable to walk at all. A woman who survived open heart surgery but lost 6 months of her life to complications that nobody warned her were even possible. These are not isolated tragedies. They are patterns, and they become dramatically more common once a patient crosses certain thresholds of age and physical vulnerability. Understanding those patterns is not about fear, it is about choices. And choices made with full, honest information are always better than choices made in the dark. Consider 2 cars sitting side by side. One just rolled off the production line. The other has 200,000 miles on it. Run them both through the same stress test and expect identical results? Nobody would. And yet, for decades, medicine applied the same surgical protocols, the same recovery timelines, and the same expectations to a 70-year-old body that it applied to a 40-year-old one. That approach is beginning to change, but not fast enough and not consistently enough. Here is what actually happens inside an older body when it goes under general anesthesia. The heart must work significantly harder than baseline. The lungs take considerably longer to clear anesthetic agents from the system. The kidneys slow their processing of medications, which means drugs linger longer and at higher concentrations than intended. And the brain. This is the detail that surprises people most. The brain becomes temporarily disoriented in ways that can persist for weeks or even months after the operation is over. There is a clinical term for it: post-operative cognitive dysfunction. Patients describe it as a heavy fog they cannot think through. Family members describe watching someone they love return from the hospital as a quieter, slower, more confused version of the person who left. In patients over 70, this phenomenon occurs far more frequently than is openly discussed or clearly disclosed before surgery. Now, one thing must be stated plainly. Age by itself is not a reason to avoid surgery. There are 80-year-olds who recover faster than some people in their 50s. Age is a number, but frailty is not. Frailty is a specific medical concept. It describes a condition in which the body's biological reserve, its capacity to absorb stress and mount a recovery, has declined below a critical threshold. It is not simply being old, and it is not simply feeling tired. It is a measurable clinical state. Roughly 40% of people over 75 show signs of frailty. That figure rises to nearly 60% in people over 85. This changes the central question that should be asked before every major surgical procedure. The question is not, can this patient survive the operation? The question is, can this patient survive the recovery? Those are 2 entirely different things. And that distinction, fully understood, has the power to reshape every conversation that happens between a patient over 60 and a surgical team. Coronary artery bypass grafting, CABG, is one of the most frequently performed major surgeries on older adults worldwide. The principle is straightforward. Arteries are blocked, blood flow is rerouted around the blockage, and for the right patient, the results can be genuinely life-extending. But what the brochures and the pre-surgery meetings often fail to show clearly is what open heart surgery actually demands of the body. The procedure requires the heart to be stopped completely. The patient is placed on a cardiopulmonary bypass machine, a device that temporarily takes over the work of both the heart and the lungs while surgeons operate on a still, bloodless field. For a 60-year-old in solid cardiovascular health, that is a manageable physiological challenge. For a 78-year-old already managing chronic kidney disease, mild diabetes, and early cognitive decline, that bypass machine is effectively a simultaneous assault on every major organ system in the body. Published research shows that in frail elderly patients, open heart surgery carries a 30 to 40% risk of serious complications: stroke, acute kidney failure, prolonged confusion requiring extended hospital stays, dependence on a ventilator for breathing support longer than anticipated, and in the most sobering finding, up to 15% of high-risk elderly patients do not survive to 30 days after this surgery. So what is the alternative? In many clinical situations today, there is one. Transcatheter aortic valve implantation, TAVI, is a catheter-based cardiac procedure that achieves its goal without stopping the heart and without opening the chest. It is less dramatic in appearance than traditional surgery. It is also far less traumatic to a body that needs support, not a second major battle. This does not mean refusing heart surgery is the right answer. It means one question must be asked clearly and directly before agreeing to any cardiac procedure. Am I a candidate for a less invasive approach? That single question, raised at the right moment, can redirect an entire treatment plan. Back pain in the 60s and 70s is close to universal. It is one of the most common complaints in older adults, and increasingly, the solution being offered is spinal surgery. Fusions, multi-level decompressions, and metal hardware implanted along the spine to hold vertebrae in fixed positions. Some spinal surgeries are genuinely necessary and should not be delayed. When a spinal cord is actively compressed and causing loss of bladder or bowel control or the early signs of paralysis, surgical intervention is appropriate and urgent. There is no question about that. But elective spinal fusion for chronic back pain in an elderly patient? The research is troubling in ways that most patients are never told. A major study published in the journal Spine found that in patients over 65, complex spinal fusion surgery carried a complication rate exceeding 40%, not 10%, not 20%, 40%, and the complications that occurred were not minor inconveniences. Blood clots forming in the legs and traveling to the lungs, deep surgical infections, hardware failure requiring additional operations, and a condition called adjacent segment disease, in which the vertebrae directly above and below the fused section begin to break down because the mechanical load of the entire spine has been permanently redistributed onto them. The hardware holds one section rigidly in place, and everything else absorbs the consequences. What is most frustrating about this picture is the outcome data on pain relief. Studies consistently show that for many elderly patients with degenerative spine disease, aggressive spinal surgery provides no better long-term pain relief than a well-designed program of physical therapy and targeted injections. The same outcomes, with dramatically higher risk attached to the surgical path. There is a principle worth remembering here. Sometimes the best operation is the one that never happens. That is not defeat. That is clinical wisdom applied honestly. This is the hardest category to discuss, because when the word cancer enters a conversation, the instinct that follows is immediate and entirely human. Cut it out, remove it, eliminate it before it spreads. That impulse is understandable. Anyone would feel it. But extensive surgical experience reveals a harder truth. The goal of cancer treatment is not simply to remove the tumor. The goal is to give the patient more good years of meaningful life. And sometimes, not always, but more often than oncology conversations reflect, major surgery in a frail elderly patient does not achieve that goal. It actively undermines it. The Whipple procedure for pancreatic cancer is one of the most technically demanding operations in all of medicine. It involves removing the head of the pancreas, a portion of the small intestine, the gallbladder, and part of the bile duct. The surgery runs 6 to 10 hours. In younger patients with good organ function, it can be genuinely life-saving and is worth its substantial difficulty. In an 80-year-old with established heart disease and reduced kidney function, the surgery may succeed technically. The tumor is removed, and the patient may still be dead within weeks, not from cancer, but from the cascade of complications that a body with insufficient reserve could not withstand. This is called futile surgery. It happens more often than anyone in medicine is comfortable acknowledging publicly. A landmark study from the American College of Surgeons found that nearly 1 in 5 elderly cancer patients who underwent major surgical resection experienced what researchers termed failure to rescue, meaning a serious complication developed that the body simply lacked the biological capacity to overcome. The question that opens new possibilities is this one, asked directly to the oncologist. If we do not operate, what would watchful waiting, radiation therapy, or targeted medical therapy look like for someone with my age and my health status? Many patients have never been offered that question. Many do not know the door exists, and sometimes, not always, but sometimes, what lies behind it is a genuinely better path. Hip and knee replacements represent some of the most consistently successful surgeries ever performed. For the appropriate patient, a new hip joint transforms quality of life in ways that are hard to overstate. People who could barely cross a room return to walking freely, climbing stairs, and spending active time with grandchildren. The results in the right candidate are remarkable. The complication arrives with the word elective. Elective means planned. It means there is no emergency driving the timeline. It means there is time to think, time to prepare, and most importantly, time to ask whether this particular body, in its current condition, is ready for this particular operation right now. In patients over 75 who carry 3 or more serious coexisting conditions, heart disease, type 2 diabetes, chronic kidney disease, significant obesity, elective joint replacement carries substantially elevated risk of perioperative complications. The most dangerous is blood clotting. Deep vein thrombosis, clots forming in the deep veins of the legs, can migrate to the lungs and become life-threatening pulmonary embolisms. In elderly patients whose circulation is already compromised, this risk is meaningfully higher than in younger surgical candidates. Layer on the risk of post-operative pneumonia, which develops more readily when patients are immobile for extended periods. Add hospital-acquired infections. Add the cognitive disruption that general anesthesia can trigger in older brains. The picture that emerges is considerably more complex than what the standard pre-surgical appointment typically conveys. To be precise, the question is not whether to ever pursue joint replacement. The question is whether the body is in the best achievable condition before that surgery happens. Optimizing blood pressure control, blood glucose management, cardiovascular fitness, and body weight before elective surgery can reduce complication rates dramatically. This preparation has a name: prehabilitation. Some hospitals now mandate formal prehabilitation programs before scheduling these operations in high-risk elderly patients. That requirement reflects exactly the right clinical thinking. Has your doctor ever discussed prehabilitation before a planned operation? If the answer is no, and for most patients it is, that conversation is worth initiating. This category is different from every other one on this list, and the difference is important. Emergency surgery is not chosen. It arrives. A perforated bowel, a ruptured appendix, acute internal bleeding. These situations do not allow for calm office conversations or unhurried second opinions. They demand decisions in hours, sometimes in minutes, often in the middle of the night in a hospital corridor surrounded by frightened family members. And yet this is precisely why the subject belongs here. Understanding the risks before an emergency happens fundamentally changes how patients and families navigate those moments. Decisions made with prior knowledge are different from decisions made in shock. Emergency abdominal surgery in patients over 75 carries among the highest mortality rates in all of surgical medicine, 30 to 50% in the most serious presentations. Not because surgical teams are inadequate, but because an elderly body confronting sudden acute trauma is simultaneously defending on too many fronts. The liver, kidneys, heart, and lungs are all affected at once. The inflammatory response that a younger body regulates within days can spiral in an older body into systemic inflammatory response syndrome, a cascade in which organ systems begin shutting down in sequence. When that process begins in a frail patient, its trajectory is difficult to reverse. What can this knowledge actually change? 2 specific things. First, abdominal symptoms in someone over 60 should never be casually dismissed. Persistent pain, unexplained bloating, and meaningful changes in bowel habits deserve prompt medical evaluation. Problems caught before they rupture, perforate, or bleed are problems that can be managed without emergency intervention. That single habit, taking symptoms seriously early, can prevent the emergency from ever arriving. Second, the family conversation needs to happen now, not in a hospital corridor at midnight, now. What are your wishes if emergency surgery becomes the only available option? What quality of life matters to you? What trade-offs are acceptable and which are not? These conversations are not grim. They are not defeatist. They are among the most practical, loving things a person can do for the family members who will be standing in that corridor being asked to decide in minutes what should take hours. Information without direction becomes anxiety. So before any major surgery, planned or recommended, 4 questions deserve to be asked and answered in full. What happens if I do not have this surgery? A good surgeon will answer this honestly. If nothing urgent changes in the next 6 to 12 months, time exists. Time to think. Time to gather second opinions. Time to improve physical condition before committing to a procedure. Is there a less invasive alternative? Surgical medicine has changed enormously in 15 years. Robotic procedures, endoscopic techniques, and catheter-based interventions now exist in most major hospitals that were simply unavailable a decade ago. The question should always be asked, what does recovery realistically look like for someone with my specific age, health conditions, medications, and living situation? Not for the average patient in a clinical study, for you specifically. The answer should be detailed and personal. If it sounds like a rehearsed brochure, push for more. What is your personal complication rate for this procedure in patients over 70? Surgeons track these numbers. A confident, honest surgeon will share them without hesitation. If the question produces discomfort or evasion, that reaction is itself useful information. Minimally invasive surgery has genuinely transformed what is achievable for elderly patients. Laparoscopic procedures with small incisions and camera guidance dramatically reduce recovery time and physiological stress. Robotic-assisted surgery provides precision in tight anatomical spaces that hands alone cannot reliably achieve. Catheter-based cardiac interventions now reach patients who would never have survived traditional open surgery. Beyond surgery itself, optimized medical management is more powerful than most patients realize. The right combination of medications, supervised physical therapy, precisely targeted injections, and structured nutritional support can manage conditions that once seemed to require surgical intervention. The body's inclination is toward healing. Sometimes the most important clinical decision is to create the right conditions and allow that process to unfold. Consider a 71-year-old man, sharp, engaged, someone who had received the same recommendation from 3 separate surgeons, open heart surgery, 3 consultations, 3 identical answers. He was not afraid of the operation itself. He was afraid of losing himself. He had watched someone close to him emerge from major surgery confused, exhausted, and fundamentally diminished. She went in as herself, he said quietly, and came out as someone I had to take care of. When his complete clinical profile was reviewed, kidney function, frailty indicators, cognitive baseline, and when the conversation lasted 40 minutes rather than 15, a different picture emerged. Surgery was an option, but so was an aggressive medication protocol paired with structured cardiac rehabilitation. For his specific profile, published data showed comparable 5-year survival outcomes between the 2 approaches. He chose the non-surgical path. 4 years later, he sent a photograph. He was standing at the summit of a hiking trail, flanked by his 2 granddaughters, both taller than him now, grinning with the uncomplicated joy of someone who had kept himself. A surgical recommendation is not a verdict. It is the opening of a conversation. You are not a passive recipient of decisions made about your body. You are an active participant in your own care, and you have been from the moment you walk through the clinic door. You have the right to ask every difficult question. You have the right to request every available alternative. You have the right to take whatever time you need before signing anything. The surgeon holds the scalpel. You hold the choice, and that choice, made with full information, honest numbers, and clear-eyed understanding, is the most powerful instrument in medicine. More powerful than any procedure. Be an informed patient. Ask the hard questions, insist on alternatives being discussed, get a second opinion, and if necessary, a third. Your age is not a liability. Your willingness to advocate for yourself is a strength that no operating room can replicate. You deserve a surgeon who explains everything clearly, shares real numbers honestly, and treats you as a partner rather than a problem to be solved. And the conversation that produces good medicine, direct, unhurried, and built on mutual respect, begins the moment you decide that your voice belongs fully in the room.